Hi, I'm Dr. Jack West, medical oncologist in Seattle, Washington. I'm just recently back from ASCO 2018, where there were a lot of interesting, provocative presentations about the role of immunotherapy and various combinations in the setting of advanced non-small cell lung cancer. And one of these was an additional analysis of the CheckMate 227 trial that we initially saw results from in April of 2018. This specifically was a presentation by Dr. Matt Hellman that was coincident with a New England Journal publication that focused on the 44% or so of patients who have high tumor mutation burden. But the CheckMate 227 trial was large and quite complex, and there was an additional analysis done and presented by Dr. Haas Borgai from Fox Chase. And I'm showing the CheckMate 227 schema here, and the focus is really just on the colored portion at the bottom for this particular analysis. This was just the subset of patients who have PD-L1 expression less than 1%. That's about a third of patients, and this study, or this portion, this cohort, was for patients with squamous or non-squamous non-small cell lung cancer, not previously treated and without an EGFR mutation or ALK rearrangement. And these patients were randomized to either histology-appropriate doublet chemotherapy or Nivo with the same doublet chemotherapy, or a chemo-free combination of nivolumab and ipilimumab. This was not a focus in the prospective design of the trial, but it was an analysis that just looked at progression-free survival and some other endpoints, and it was interesting in showing a significant improvement in progression-free survival with the Nivo chemo combination compared to chemo alone in this subgroup of patients with PD-L1 less than 1%. And that's shown in these curves here for PFS. And you can see that although there's not a real difference, not much of a difference at the median, less than a month difference favoring the triplet, the hazard ratio is significant, and the curves separate and stay separated for a long period, so that by a year out there's a substantial difference favoring Nivo and chemotherapy compared to chemotherapy alone. When you turn to response rate, you could see that the difference is about 14% with, or close to that, 36.7% response rate with the Nivo chemo versus 23% with chemo alone. And the duration of the responses was higher, significantly so, with the Nivo chemo combination. That's shown in the curves on the right side of this figure. Now, turning back to progression-free survival with Nivo chemo versus chemotherapy alone, it's important to note that across the different subgroups, there was a strong trend toward better results overall with Nivo and chemotherapy, but there are some subgroups that are really worth more attention where the differences weren't that clear. First of all, as was highlighted in the abstract, but really not touched on much in the presentation itself, the squamous subgroup did not see a significant benefit, and the hazard ratio in the squamous subgroup was 0.92. So for whatever reason, not a big difference here. There was a lot more focus on tumor mutation burden as an important factor, and that is shown in the forest plot here. But it's also blown out and talked about much more in Dr. Borgai's presentation and several other curves. And so turning to the figures for high TMB patients with low PD-L1, you can see that the benefit with Nivo chemo over chemotherapy alone was specific to the patients with high TMB. That's the curve on the left side. In contrast, the patients with low tumor mutation burden, which was defined as a threshold of 10 mutations per megabase, that's shown in the curve on the curves on the right side. There's no difference favoring Nivo and chemo in that group. Now, when they also did a a summary of the results by in high TMB that included Nivo and ipilimumab, and the best group of all was that subgroup of patients who had Nivo and Ipi, where the hazard ratio for PFS was 0.48 compared to 0.54 for Nivo and chemo, and both of these look better than chemotherapy alone, but that's really only in the high TMB group, as we'll see. Now, they highlighted that the duration of response was especially promising in the high TMB, low PD-L1 group in those patients who got Nivo and Ipi. And you can see that at 1 year, the progression-free survival is 93%. Great, but we're talking about a very small number of patients here, and so nothing conclusive, but just a compelling suggestion that these responses may be particularly long-lasting, and we'd love to see more on this. Now, there was no benefit with Nivo Ipi or chemo with Nivo compared to chemo alone in the group of patients who had low TMB, and that's shown in the curves on the right. You can see really they travel together, and the benefit was specific just to the high TMB patients, whether getting Nivo chemo or Nivo Ipi. So what do we take from this? Interestingly, Dr. Lina Gandhi alluded to this concept of favoring Nivo and ipilimumab for patients with high TMB and low PD-L1 in her plenary discussion on the Keynote-042 trial. But I would say that without an overall survival benefit, I think it's still premature to clearly favor this as any kind of standard of care. I would say that if you do have tumor mutation burden already available, and you know that it's high, particularly in the patients with low PD-L1, and this group of high TMB, low PD-L1 is just about 16% of the broad population. That's a group in whom I think it would be most compelling to consider Nivo-Ipi, but this is also a group of patients who are candidates for a chemo-immuno combination, such as the Keynote-189 approach, for patients with non-squamous histology, or the Keynote-407 trial with squamous. So those are still strong options to consider, but it is fair to say that the patients with low PD-L1 are the ones who got the least benefit overall with chemo and chemo-immuno combination. So I think it's worth considering, and tumor mutation burden still has some more work that we need to corroborate. I think we really need to see an overall survival difference before we consider it a standard of care. But this does feed the narrative and the strength of the data supporting Nivo and Ipi for a subset of patients, and it may be best for this group with high TMB and low PD-L1. I would welcome your thoughts on this and encourage you to leave your comments, questions, objections, whatever, and I hope you'll like, comment, and subscribe. More later.